So I'll just start. So this was a 2-month-old baby infant. He was 4.5 kgs, otherwise a developmentally normal and healthy child. And this child had presented complaints of fever for 2 days. It was like day 2 of fever. The child was excessively irritable and he had breathing difficulty since 1 day. And the child was not passing urine as per the parents since last evening, the day before admission. And there was a history of a routine vaccination which was done 2 days back. So, the fever was continuing after that, but otherwise the child was had no previous any history. The birth history was normal. The child was a term delivery, and it was a normal vaginal delivery. Birth weight was good, and there was no history of any NICU stay. So on assessment of this child, when the child came to the emergency room, the airway was maintainable. The child had visibly, the child was in distress. It was tachypnea was there, and the child was not maintaining saturation. He was hypoxic, saturation for around 80s, and the air entry was at that time equal on both the sides. In cardiac system, the tachycardia was there. The heart rate was 160, but it was still in sinus. The pulses were not palpable. The central and peripheral pulses both were not palpable, and the blood pressures were not recordable, and the perfusion was delayed. In disability, the child was lethargic. The GCS was around 8, and the pupils were otherwise equally reacting, and the child had cool motile skin with poor perfusion. So, for any sick case, we would like to do a blood gas immediately. We put the cannulas, we correct the sugars for this child, and we did a blood gas. And in the blood gas, we can see the child has severe metabolic acidosis, a pH of 6.9 with very high lactates of 9.1 and bicarbs of just 13. So at this point of time, we were thinking whether what can be the etiology, whether it is metabolic or whether it is respiratory, because the child had symptoms of breathing difficulty, or whether it was a cardiac or like a congenital heart disease. But then there was no previous history, and it's a very short acute history of just 1 day. So the child is managed appropriately. We start the child on oxygen. The IV lines that we secured, boluses has already been started before we could reach the emergency room. And after the bolus, it was seen that the child heart rate had gone up from 160 to 190. The child had become more distressed, and now there was a palpable liver at that point of time. And on auscultation, the child had bilateral crackles. So crackles had developed, and the rhythm had changed to a gallop rhythm. So clearly, at this point of time, it was seen that the child was fluid intolerant. Means he was not tolerating the fluid. That fluid bolus had actually deteriorated him. So this is not like your usual shock where will you give a bolus and the child is expected to improve. Here the child has deteriorated. That was the first X-ray which we got. Some clue was could be got from there that we can look that the heart size is little enlarged. So I hope there are DNBs and postgraduates. So this next few slides are for you. So in this X-ray we get idea that the child is having cardiomegaly and now the child is fluid intolerance. And we have a point of care ultrasound system which we do it in the emergency for all the sick child. So ultrasound is available. We do a ultrasound and we look at the cardiac function. So clearly it shows this is the left ventricle. So there is severe LV dysfunction. This is your IVC. The IVC is fully dilated. And at this point of time, the diagnosis is fairly clear to us. It is a case of cardiogenic shock. This severe LV dysfunction is there. And so immediately the further fluid boluses has been stopped, and we have initiated the child on peripheral inotrope with adrenaline was started. So this is a very important time. At this point of time, we know it's a cardiogenic shock. So there are certain pearls which you have to remember when you're managing a case of an infant who are presenting with this kind of cardiogenic shock. First of all, that this is a ticking time bomb. So these patients can collapse anytime with a fluid bolus or any form of stress you give, the child can collapse. So the main point of care at this time is to avoid any stimulus to this child, and we have to safely intubate this child because we need to take control of the situation. Okay. So from the physiology, we know that there has to be a balance between oxygen delivery and oxygen consumption in case of shock. So here the delivery is compromised because the heart is compromised, and there is a lot of consumption because the child is in shock. The requirements are high. So you have to optimize that. And before you go in for intubation, the most important point is to have a control of the situation. So how will you do that? We proceed for intubation, but you start adrenaline. I mentioned that is very, very important. Keep a adrenaline syringe loaded before you intubate this child, because then you will not get time. If you just proceed for intubation without adrenaline, the child will collapse and will have lost the child. So start the adrenaline, connect oxygen prongs, start him on oxygen, re-oxygenate it. That is very, very important. and continue your adrenaline. And then for intubation, you need drugs which are cardiostable. So for sedation, we can use ketamine because the blood pressure was not recordable. So ketamine is a good agent; it will improve your blood pressures. Or you can use fentanyl, and also you have to use a muscle paralytic. Again, you have to remove the noxious stimulus. So you use a rocuronium and you intubate. And once the blood pressures are fine, maybe in next few hours you have to try on using a inodilator like milrinone. So the child is intubated, brought to PICU on infusion, and these are the reports we get that troponin and pro-BNP are elevated, and we confirm that's a case of congestive cardiac failure due to cardiogenic shock. So this is the course of events over next 8 hours, where the child was intubated and continued on ventilation. And then we see that the inotropic requirement was not coming down. In fact, we had to go from every high dose to then NORAD. And then we saw that the child over not 4 hours was not passing urine. The child had become totally anuric. And then unfortunately, the child also developed refractory arrhythmia. So he went into ventricular arrhythmias. VTAC started happening. We had to DC cardio ward the child also once. With all these conditions, in the blood gas, we saw that there was hyperkalemia also. So potassium had gone up to 7 with no urine. And with this worsening renal status of anuria, we had to proceed with the peritoneal dialysis. So we had started the child on peritoneal dialysis on the bedside, and meanwhile we have involved our cardiologist, Dr. Gaurav was there. He's not there right now. So Dr. Gaurav was involved, and we had counseled the parents that in the setting of this refractory cardiogenic shock with onset of arrhythmias and AKI, it's a case of fulminant myocarditis with cardiac failure. In this case, except ECMO, there is no salvage therapy available at this because we have already exhausted the medical management. So with this position, and we have repeated the blood gas also, and at that point of time, the blood gas was showing a lactate of 16. So child was already worsening on high inotrope with worsening multi-organ failure. The child was decided to be kept on ECMO. And when the child was shifted to OT, even before the ECMO could be initiated, the child had cardiac arrest, and 5 times GC cardioversion had to be given to this child to revive him. So this was the child which was brought to the PICU after the initiation of the ECMO, and we were very fortunate that within 8 hours of presentation to the hospital, the child was on ECMO. So that kind of X-rays you will see with ECMO, there are a lot of cannulas inside. So just a brief about what is an ECMO. So basically ECMO is what? It's an extracorporeal membrane oxygen. Basically it is a bypass because your hearts are not working, and also in case of pneumonia where the lungs are not working, you have to bypass the heart and lung. You have to oxygenate your blood because heart is not working, there is no cardiac output, the lungs are not functioning. So in those cases, ECMO is a lifesaver. It's a bridge therapy to allow the organs to heal. Okay. So then we proceed with the ECMO, and timing of initiation of ECMO is very important. So there are studies which have shown that the time to initiate the ECMO is very critical. So if you are able to initiate the ECMO before the multi-organ failure starts, within 24 hours, the outcomes are very good. So these are two types of ECMOs which we discussed. One is veno-arterial VA ECMO, another is the veno-venous ECMO. So veno-arterial ECMO is there when it's a purely a cardiac problem, where your heart is not functioning, like in case of post-cardiac surgeries, or like in this case, cardiogenic shock, or it can be done in respiratory causes like severe pneumonias. So to take over the function of the heart and lungs, so we accordingly decide whether we are doing a veno-arterial or a veno-venous. And what do you mean by veno-arterial means? For this, there is always an outflow. You have to withdraw the blood. So the blood is coming from the vein, and in veno-venous, the blood is returned to the vein. So maybe it's coming from the femoral, and you give it to the IJ, and because your heart is functioning well, the system keeps on moving. But if it's a veno-arterial where your heart is not functioning, you cannot return the blood to the venous side. The blood has to be returned to the arterial side. So we withdraw from the femoral, we give it in the arterial, maybe aorta or carotid. So just to show that this is a membrane oxygenator. So this is your artificial lung, and that is your pump which will pump the blood to the system. Cannulations are a big issue in this because this was a neonate, and this was our youngest ECMO kit. What we have done is just a 2-month-old baby. Cannulation availability is a very, very big issue. So giving an option of ECMO is very easy, but then to initiate ECMO within such a short span of time, getting the cannulas, getting the perfusionist, getting the cardiologist, CTA surgeon was really miraculous in this child. And as you can see, then the cannulation has to be kept into the main vessel. This is a small child, so the peripheral vessels cannot be used. You just cannot use IJ or femoral artery. Here we had to open the chest. So in small kids, we do a chest open. So we are putting the outflow cannula in the right atrium, and the drainage cannula, which is returning the blood, goes to the aorta or the carotid artery. So it's a big tedious task. It has to be done in the OT only, with very high chances of mortality also. So this is from the ECMO registry, which shows that over the years, these green bars are showing that over the years ECMO have increased in such cases, and the survival rate has also increased over the last 20 years. The survival cases have also increased. This is the April 25 registry data of ELSO, which shows that outcomes have improved in case of pediatric ECMOs, especially for pulmonary and cardiac. So the outcomes are like beyond 50%. So 50 to 60% survival rate is there if you initiate ECMO properly on time. So this is our child on ECMO. So this was the chest open. So this was the chest open. These are the cannulas. So the blue one, the darker one is the venous, and the bright red is the arterial. So that's the ECMO machine. Child is on the ECMO machine and it is running, and the vitals were stable most of them. So post 12 hours of ECMO, the vitals have improved, tachycardia has improved, perfusion has improved, and peripheries are warm, and we have got a blood pressure. So over the next few days, the child was decannulated after 6 days of ECMO. So on that point of time, we were happy that yes, the child has made it through. But then because the general condition was still bad, the child ended up in sepsis, and unfortunately the child developed sepsis after like 4 days of ECMO, and he had developed multi-drug resistant Klebsiella sepsis, so which was present in the mediastinum, DET culture, the peritoneal drain, PD was still going on at this point of time. So the child developed Klebsiella sepsis, and we had to really struggle with this sepsis because for 3 weeks the multiple cultures were coming positive, and the child was severely malnourished. From 4 kgs, the child had gone to 2.8, 2.9 kgs, and we were struggling for the weight gain. So it took us 3 weeks to aggressively work on him, and finally, after 3 weeks, the weight gain started, and the child could be extubated and brought to NIV. So these are just pictures of this sepsis part. The wound was gaping, was present, pus culture was coming, so everything was positive in this child. So this is how the X-rays progress from this. Ultimately, this was the X-ray one before discharge. So child was doing good, and so as I mentioned, there was a big rehabilitation phase which went on for almost 3 weeks, and the child started gaining weight, and this concluded with a smile. My parents were also very happy. But then, as I mentioned initially, mayhem was going on. We had reached this stage after 50 days, but then the time came to decannulate the child because the child was discharged on tracheostomy. And then the child came after 15 days. We tried to decannulate the child, but we could not because there was this. We did a bronchoscopy. There's something here. This is a granulation tissue. So because of this, his clinical condition, because of that lot of hypoxia and prolonged intubation, so the child developed granulation tissue near the glottis, which was preventing his decannulation. So on tracheostomy, they will be fine, but the time you decannulate, the granulation tissue will obstruct the airway, and the child was getting striders and severe distress. So difficulty in extubation was there. So for that, bronchoscopy was done, and Dr. Ankit is a pediatric pulmonologist. He did these procedures. Doctor, if you can tell about this. Dr. Ritika can tell about, but she is part of the pediatric pulmonology. She can tell about these procedures which we did.
So, when we diagnosed the suprastomal granulation, this child was not able to maintain his saturation. He was in distress and had stridor on regular on room air. This child was dependent on NIV basically, so we had to intervene. So in the first video, we have used electrocautery to remove the suprastomal granulation. The biggest challenge in doing this procedure was that the baby was just 5 months old when we did, 4 or 5 months old when we did this procedure. So luckily we have the equipment with us, but then because he was so fragile, dependent on NIV, getting the right sedation, maintaining the airway and still doing an electrocautery procedure in a small airway space, it was a bit challenging. But then we had the whole PICU team with us for, we did a nasopharyngeal intubation and then we gave sedation to the child. And in the first video, we can see that in the second one, we can see that the whole, So in the second one, we have cauterized that area. The suprastomal granulation is cauterized, and In the third one, we can see that there is some slough formation around it. This bronchoscopy was done 2 days after the procedure before we discharged the patient. And there was some slough, but the airway caliber was improved as compared to before. So at this point, this child was discharged home and was called for review after 2 weeks.
But then this procedure had, because of the granulation tissue, then we have to do a balloon dilatation also. So if you can explain.
This child, as far as I remember, again had problems with breathing. He had respiratory distress again, and then we repeated the procedure, and we saw that the airway was still narrow. In the suprastomal area was still narrow, so we did a balloon dilatation. And after the balloon dilatation, the child is doing fine. The airway is okay. There is no inflammation. Why we didn't do balloon dilatation in the first setting is because the airway was inflamed. There was active inflammation. In that acute inflammatory state, if we do a balloon dilatation, we might damage the airway more. So we waited for some time before attempting the balloon dilatation.
So this case was managed successfully. The child has come for follow-up till date multiple times, and he is doing fine right now. So I'll say like this was a collective team effort. Initiating an ECMO may be still easy, but then you have to be aware of the consequences of any complications which can happen later on. So you need to have a full team which can take care of the complications. In this, we have the support of the pediatric cardiologist, the cardiac surgeon, Dr. Tarun is there, pulmonologist, Dr. Ankit was there, and a whole team of nutritionists is there. Then OTPT team was there, which was providing physiotherapies. Then the dietitians, so important like for chest physiotherapies to have a good outcome. So everything has been coordinated well, and the child came out well in this. And this was on the last follow-up. Child had gained weight, almost like 6 kgs. The child was there right now. And this is our hospital pediatric ECMO data. Till date, we have done 6 ECMOs, and we had success in 3 cases. So my take-home message is that not every shock needs a bolus. A proper reassessment is required before you do your fluid bolus, because that can be detrimental in case there is a cardiac dysfunction. And always be aware of the fluid overload. So every fluid bolus has to be calculated. It can lead to worsening. So be cautious of the fluid overload, because that will affect your outcomes. And intubation in cardiogenic shock is very high risky. Experience will matter. So have a senior should be there always, and always have adrenaline loaded on the bedside. ECMO in such fulminant cases can be life saving, and if available, you should be started immediately. And early ECMO is the key. Thank you.
Very well managed case, really eye-opening. Most of the time, the myocarditis we attributed to oxycovirus. What could be, and we had similar case, we could salvage the case that was probably we attributed it to post-DPT vaccination.
This is post DPT.
So in that case, somehow we could salvage that baby with the use of methylprednisolone. What is your take on that? Once you are in a shock-like situation where fluid is a big no, so
steroid.
We just speculated that it could be post-DPT.
So this patient also post DPT